What's up, everybody? I'm Dr. Maxwell Cooper from DaVinci Academy, and welcome back to another episode of DaVinci Cases, Inside the Boards edition. Inside the Boards is a medical education podcast platform that we've teamed up with to bring you a new series of video and audio clinical cases. Dr. Patrick Beeman from Inside the Boards and I will be walking you through these cases together, highlighting question dissection tips and how to apply concepts towards finding the correct answer. All right, everybody, welcome back to another episode of DaVinci Cases Inside the Boards edition. So we'll start you off here. For this case, we have a 54-year-old man presenting to the emergency department with vision changes that started 5 days ago with no apparent cause. So we've just got a middle-aged guy here. He's got an acute change in vision and coming to the ED. His vitals are within normal limits. And then his neurological exam demonstrates normal motor strength, sensation, and reflexes throughout all 4 extremities. So he doesn't have any kind of motor deficits, no sensory deficits or anything like that. Right now, all we know is just these vision changes. So they do a vision test, and it reveals that the patient is unable to visualize objects in both of his temporal visual fields. So his temporal visual fields would be his outer visual fields. So he's not able to see peripherally, if you will. The patient drinks 6 beers per day, smokes 2 packs of cigarettes per day, and denies illicit drug use. So just some social history. Obviously smoking 2 packs a day would put you at risk for definitely cardiovascular disease and cardiovascular problems. Past medical history is significant for hypertension, diabetes type 2, which also both put you at risk for cardiovascular disease. And then in the case of a neuro case, all of those would put you at risk for stroke as well. So imaging of the head and neck would demonstrate which of the following abnormalities: occlusion of the left middle cerebral artery, aneurysm of the anterior communicating artery, aneurysm of the left posterior communicating artery, and D, dissection of the left internal carotid artery. So I will turn it over to Patrick here to go through the case here.
Yep. So just to reiterate some of the, notable pertinent positives, negatives. You've got, somebody who's in their 50s with an acute presentation to the ED. Chief complaint is vision changes that started without any identifiable cause. Vitals are normal, and you've got a essentially normal neuro exam from the neck down, and he's got visual field testing that makes him see essentially tunnel vision, so an absence of temporal visual fields, also referred to as bitemporal hemianopia, and we are trying to decide what imaging finding we would see in this patient's case. And just to reiterate, it was choice A, occlusion of the left middle cerebral artery, B, aneurysm of the anterior communicating artery, C, aneurysm of the left posterior communicating artery, and D, dissection of the left internal carotid artery. So the correct answer here is choice B, aneurysm of the anterior communicating artery. So this case will likely come down just to knowing the distribution and coverage of each of these vessels. So let's take a look at that, I guess, the anatomy, which I'll turn it back over to you, I think, since, radiology.
Yeah, no worries. All right, so since this patient was presenting with a bitemporal hemianopia or a visual field defect, let's review the visual pathways here. Just to understand some of the common visual field defects you might encounter on a neuroanatomy exam or on a USMLE. So remember, you have your left visual field and your right visual field, which corresponds to the left and right eye, respectively. Now, you can further break down the visual fields into the lateral or temporal visual fields or the nasal or medial visual fields, both on the left and the right. And your temporal visual fields also correspond to your peripheral vision, if you will. Then when you get within the eye, you actually have the temporal retina and the nasal retina. Now, this is the first place of many where things get crisscrossed in the visual pathway. So the temporal retina actually receives inputs from the nasal visual fields or the medial visual fields, And then the nasal retina receives visual inputs from the temporal visual fields or the lateral visual fields. And then going down, they both travel via the nasal and temporal fibers, respectively, in the optic nerve. So if you have a lesion in the optic nerve, you're going to impact both of those fibers. So you're going to lose all of your vision for that particular eye, which is called a left anopia. Now, what this diagram also shows you up here is that for each eye, the visual field can be broken down into 4 quadrants. So you have the superior quadrants, the right and left superior quadrant, and then you have the right and left inferior quadrants as well. And you'll see why that's important in a second here. So you keep traveling down, and then you reach a structure called the optic chiasm, which is just above the pituitary gland. And the optic chiasm is where some crossing over occurs as well. So this is actually where the nasal fibers will cross over, which are carrying those temporal visual field inputs. So you can see where the nasal fibers from the left optic nerve cross over to the right side of the brain, and then the nasal fibers carrying the right visual field temporal inputs from the right in the right optic nerve, they cross over to the left side of the brain. Now, the reason this is important is if you interfere with that crossing over, you actually lose those inputs and you lose your temporal visual field in both sides because you're impacting the crossing over from both sides. So that's why you get this bitemporal hemianopia, or tunnel vision as it's called. Now, what's important to note here is that the temporal fibers, which are receiving your medial visual field input, those don't cross over. So you can see here on the left side, they stay on the left side. And then these right temporal fibers here on the right side, they don't cross over either. They stay over on the right side. So they're not impacted by that. It's only the fibers that cross over. And so that's why a pituitary tumor as well, since it's just below the optic chiasm, can also cause a bitemporal hemianopia. So moving on, then you have the temporal fibers from the ipsilateral side and then the contralateral nasal fibers now traveling together in the optic tract. And so if you have the optic tract that's affected, what you get is a contralateral henominous hemianopia. So here in the diagram, we show that the left optic tract is affected, and so you're going to have a right henominous hemianopia. So since the left optic tract is affected, you're actually going to lose the right visual field in both eyes. So what that means is, remember how we talked about the quadrants? So both the superior and inferior quadrants on the right side and the left eye will be lost, and then both the right superior and inferior quadrants of the right eye will be lost as well. So going from there, these fibers actually synapse on what's called the lateral geniculate nucleus, or the LGN. And then from there, what they do is they split. So then you have some fibers that are traveling in what's called Meyer's loop. And I'll show you a little diagram here in a second that'll better illustrate that. But the thing about Meyer's loop, so Meyer's loop actually travels out more lateral into the temporal lobe, and it's carrying the fibers that correspond to the superior quadrants. So if you have a lesion in Meyer's loop, what you're going to have is a contralateral superior quadranopia. And so here we show this where you have a lesion in the left Meyer's loop. So you're going to have a right superior quadranopia. So the right superior quadrant of both eyes, you'll lose vision in both of those quadrants. And that's what gives you this pie in the sky visual field defect that you'll hear about. And so at the lateral geniculate nucleus, the other fibers split into the dorsal radiations, which go through the parietal lobe and kind of travel almost at a 90-degree angle or orthogonal to Meyer's loop. And we'll show you a diagram to better illustrate that in a second here. So with that, what you get is they are carrying the inputs from the inferior quadrants. So if you have a lesion that affects the dorsal radiations, you're going to have a contralateral inferior quadranopia. So here we show it on the left side. So you're going to have a right inferior quadranopia. So you're going to lose vision in the right inferior quadrant of both eyes. Now, so here's the diagram here that I'm referring to. So you have the lateral geniculate nucleus. Then you have the primary visual cortex, which is in the occipital lobe. And then you have Meyer's loop, which kind of travels out laterally here, as I show here, and is in the temporal lobe. And then at a 90-degree angle of that, you have the dorsal optic radiations that come and kind of travel superior in kind of an arch-like fashion. And they travel up into the parietal lobe more superiorly. Those are carrying your inferior fibers, if you recall. And then your Meyer's loop is carrying your superior inputs from the superior quadrants. And so again, it's just another way to visualize this. Things to keep in mind. So if you have lesions affecting the parietal lobe, that can give you a contralateral inferior quadranopia because that can affect the dorsal optic radiations. An example of that would be if you had a brain tumor in the parietal lobe, can do that. Also, if you have a PCA, a posterior cerebral artery infarction, that can affect it as well because that's the vascular territory for the PCA. And then with Meyer's loop, any temporal lobe lesion, so a tumor in the temporal lobe can give you a contralateral superior quadranopia. The other thing is if you have MCA strokes. So if you remember, the MCA kind of has a pretty wide territory, more laterally, definitely into the temporal lobe. So an MCA stroke can also cause a contralateral superior quadranopia. The other thing, as I'm showing here in the diagram, is the MCA territory also includes the optic tract. So depending on the distribution of the infarction, you can also have a contralateral homogeneous hemianopia as well with an MCA stroke. So keep that in mind as well, that visual field defects can be caused by a number of different pathologies, both vascular and tumors and otherwise. So coming back here, let's first go over the vascular anatomy very briefly. The Circle Willis, very high yield for the USMLE, neuroanatomy exams. Your neuro shelf definitely would be useful for that. And then obviously if you go any further where internal medicine, neurology, you'll definitely need to know this stuff. Internal carotid artery comes in like this, and then it bifurcates essentially. It doesn't do a great job of showing it here, but you have the middle cerebral artery that comes off and goes this way. And then you have the anterior cerebral artery that comes this way and supplies more of the medial aspect of the brain. It gives you that kind of mohawk distribution if you look at it in a sagittal plane. And so you have, everything's symmetrical. So this side as well, you have your middle cerebral and then giving off your ACA as well. And then you have what's called the anterior communicating artery, which forms kind of the anterior portion of the Circle Willis, or an anastomosis between your ACAs. And then you have your PCOMs, or your posterior communicating arteries, and these form anastomoses with your posterior cerebral arteries, which are part of the posterior circulation, which are coming off of your basilar artery, which is formed by your vertebral arteries joining together. So as far as our case, this most likely due to a cerebral aneurysm. So a cerebral aneurysm is kind of an outpouching of a blood vessel, and an aneurysm can happen theoretically anywhere in the body, but cerebral aneurysms are particularly relevant just because of how devastating, and then obviously the neurological effects they can cause. So they usually occur at bifurcations in the Circle Willis. They can sometimes occur at the MCA as well, along the course of the MCA, but usually you're going to see them kind of forming, at the anterior communicating artery junction with the ACA or the PCOM junction, either in the anterior or posterior circulation. Sometimes they're just incidental, meaning or idiopathic, meaning we don't know what causes them, but there are certain risk factors. So if a patient's elderly or older, if the patient has hypertension, because that's putting increased stress and pressure on the vessel wall, smoking, because smoking damages the vascular structure. So these things can obviously put patients at increased risks. There are some genetic syndromes you want to be aware of that are particularly important for the board exam. So it's associated with Ehlers-Danlos syndrome. So a common thing would be if a patient comes in with some neurological deficits and then they also have, hyperflexible joints or something like that. And then autosomal dominant polycystic kidney disease can be associated with cerebral aneurysms as well. They're often asymptomatic, as I said, until they rupture, unfortunately. The only exception to that is they can compress surrounding structures, which results in symptoms. And so that's what we have in this patient. This patient's not coming in with a subarachnoid hemorrhage. Remember, subarachnoid hemorrhage is, quote unquote, the worst headache of my life, or a severe headache, which is when these rupture and fill the arachnoid space with blood. So if we come here to the brain, this is an inferior view of the brain here, and then here's that Circle Willis shown again, and then here's that optic chiasm here, here's the brainstem here, just to kind of orient yourself. And then if we blow that section up and give you a closer view like this, so we have the ACOM, or the anterior communicating artery, there between both of your ACAs there, and then if you have your optic chiasm just posterior to that, so you could imagine if you have an aneurysm of the ACOM, you can very easily compress the optic chiasm and give you that bitemporal hemianopia, or where those nasal fibers are crossing over, carrying the visual inputs from the temporal fields. and which would give you that tunnel vision effect. And then just for completeness sake, because it also shows up a lot on the boards, is if you look at the PCOM here, the posterior communicating artery coming between the PCA and then the MCA here, you also have cranial nerve 3, which travels right here, comes off the brainstem just adjacent to that and travels in the same region. So if you have an aneurysm of the PCOM, you can actually get an ipsilateral cranial nerve 3 palsy, which gives you, that down and out finding on visual exam of the eye, and you can get midriosis or blown pupil with that as well. So that's definitely something you want to be aware of as well. So that could be another, otherwise the patient's asymptomatic, but they come in with vision changes and it's due to this, cranial nerve 3 palsy. So definitely want to keep that in mind for your boards. So if we come back to the question here, we're going to run through the different answer choices.
Yeah, so in this case, our first choice was occlusion of the left middle cerebral artery. And so, for me being out of med school for quite a while, still, I would expect to see in the vignette something related to a motor deficit in the upper body and lower body, right? Yeah.
Yeah, it would be the contralateral side, and it's more sort of the upper extremity than the lower extremity. Lower extremity would be anterior cerebral artery.
Okay, cool. So without that motor deficit, I think you can pretty much just, strike this one off as a likely answer choice because, in the vignette, it just says neurologic exam and demonstrates normal motor strength, sensation, and reflexes throughout all 4 extremities. So an occlusion, in summary, of the left middle cerebral artery would be right upper extremity weakness, some dysarthria or speech changes, and a right-sided facial droop. Those would be the expected findings. Choice B was, of course, the aneurysm of the anterior communicating artery, which was our correct answer. The compression of the optic chiasm, as you see also in pituitary adenoma, will result in a bitemporal hemianopia or tunnel vision with loss of the temporal-sided visual fields due to an interruption of the nasal-sided optic fibers, optic nerve fibers that cross over at the optic chiasm. Next up, aneurysm of the left posterior communicating artery. So I think this was what you really just mentioned, that compression of the same-sided cranial nerve 3, the oculomotor nerve, will lead to a down and out eye position, mydriasis, and ptosis. So is there anything you can offer just about the anatomic cause of that down and out eye position? I always remember, superior oblique muscle is the 4th cranial nerve, so SO4. LR6, the 6th cranial nerve, will be responsible for lateral eye movement. The lateral rectus muscle is the 6th cranial nerve, and then SO4, LR6. Is it all others is 3?
Yeah. All others are cranial nerve 3. Yeah, all the rest are cranial nerve 3. Okay. Yeah, and the way I like to explain this is that you want to think of the eye muscles almost in equilibrium. And so if all the cranial nerves are intact, like Patrick mentioned, 3, 4, and 6, the eye's going to look dead ahead. Versus if you knock cranial nerve 3 out, all those muscles have no inputs, so they're just kind of hanging out there. And then the superior oblique and the lateral rectus can then act completely unopposed. So if they're completely unopposed, they're going to pull their eye, they're going to pull the eye to the movements that they contract in. So they're going to pull the eye down and out. And so that's how you get that down and out, because there's no corresponding force or equal force to pull that eye back into the neutral position. So again, Patrick explained it perfectly. You have, still cranial nerve 6 and cranial nerve 4 intact, and that's how you get that position.
All right, cool. And then dissection of the left internal carotid artery was the final answer choice D. So cause of this, usually traumatic and presents with Horner's syndrome, headache, and a potential secondary stroke, which is mostly going to be in the MCA distribution from just the blood not perfusing adequately the distribution of the ultimate terminus of the left internal carotid artery, which would be the left middle cerebral artery.
Yeah, just a reminder, Horner syndrome, remember just PAM, ptosis, anhidrosis, and meiosis. So those are causing, that's due to you're knocking out your sympathetic input because those fibers travel essentially around the internal carotid artery. So if you affect the internal carotid artery, you can damage those fibers as well. Just to summarize this again, this is a patient who had a cerebral aneurysm of the anterior communicating artery that was, until 5 days ago, as the case says, was otherwise asymptomatic, but then started developing vision changes, which were due to this aneurysm essentially probably grew to the point of compressing the optic chiasm and then gave him this tunnel vision visual defect. Thank you for watching this video from this new collaboration between DaVinci Academy and InsideTheBoards. Again, to listen to the audio, you can go to the InsideTheBoards platform or wherever you listen to podcasts. Again, to see that all the DaVinci Academy and InsideTheBoards have to offer, be sure to click the links in the description below. Thank you again for watching.